Oh, thank you.
Yes, unfortunately, there's a sort of knock-on delay that's happened, as we all know, and then there was the IT problem. So I think what we all feel is that after each talk, there'll be one or two questions, given that the discussion period at the end might not take place. In that regard, Simon Ray was told us this morning, for those of you who weren't here, about a very interesting clinical study that's taking place in assessing surgery versus medical management of asymptomatic mitral valve repair candidates. But today, I think, now Simon's going to tell us about a sort of cardiological perspective of commissioning going forward. Obviously, this will mainly pertain to the UK, but we'll be hearing the American perspective later from David Adams.
Yeah. Thank you very much indeed. So a lot of what I'm going to say, I think is going to be self-evident after what has already gone past in the session this morning and to some extent in Ben's talk. And I think the first thing just to stress is the gap between what is in the guidelines and what actually happens in reality. So I think everybody accepts mitral valve repair for degenerative mitral regurgitation is the preferred technique when it is expected to be durable. And so I think the first question is, do we know that a lot of the mitral valve repair done in the UK, done elsewhere, is durable? I think the answer to that is generally we don't, because it's not looked at systematically, and clearly that is an important issue. And that's a class 1 recommendation. When you get down, and this is the European guidelines, when you get down to class 2A recommendations, it becomes even more blurred, really. So again, surgery should be considered in asymptomatic patients, preserved LV function with a high likelihood of durable repair, low surgical risk. Well, how do we define those? Is that information out there, and is it routinely audited? And the same again, surgery may be considered for asymptomatic patients with preserved LV function, high likelihood of durable repair, low surgical risk. So these are extremely important issues that we need to tackle. This slide's been shown a couple of times already. Ben's just mentioned it. I think it's important for three reasons. First of all, it illustrates the disparity in the range of the amount of mitral valve repair that's done as a proportion of mitral valve surgery for regurgitation, for degenerative regurgitation in the UK. And I think it's also important to emphasize that this is not just a surgical problem. This is a systematic problem, because a substantial number of these patients were presenting either with reduced left ventricular ejection fraction, about 25% in this time frame, and somewhere over 40% in MYHA class 3 or 4. So it had already gone beyond the point at which surgical indications are standard. So we have a problem. Patients are not being followed up as well as they should be, and we don't know how successful surgery really is in many instances. And it becomes important, and again, most of you, I imagine, will have seen this data, which again was published in the Blue Book 5-6 years ago now, looking at surgery for degenerative mitral valves in patients who are asymptomatic, MYHA class 1 with good left ventricular function. Looking at the numbers of repairs and replacements, so most getting repairs, but probably 25% or so getting a replacement instead. But more importantly, the respective mortality, about 10 times as high in those patients who received a replacement as opposed to a repair. So these are individuals who are going in asymptomatic with normal left ventricular function to surgery, and 6% of them are not surviving the procedure in the perioperative period. So that's a very substantial problem. We're not unique. There are also issues in the United States. Again, this data was shown briefly this morning. And there is, at least in US practice, a pretty clear relationship between institutional volume and outcome. And high-volume centres in this US registry are defined as centres of more than 140 cases a year. And there are very few centres, if any, in the UK performing those sort of numbers on a consistent basis. So there is a gap between the expectation of the guidelines in terms of what is low mortality, what is likely durable repair, and what is actually being done in practice. And these, the next couple of slides I'm going to show are from the US guidelines, which were published just a couple of days ago, because I think they start to make some very important points about the future of subspecialisation of practice in valve disease, both cardiological and surgical. So if you look at these guidelines, here we go. Mitral valve repair is recommended in preference to MVR when chronic severe primary regurgitation is limited to the posterior leaflet. So anatomy starts coming into it, so we need to record anatomy. MV repair is recommended in preference to MVR when surgical treatment is indicated for patients with chronic severe mitral regurgitation involving the anterior leaflets or both leaflets. Again, successful or durable repair. So if you're going to follow this guideline, we need to know the outcomes for institutions and for individual surgeons. And you'll note these are Class 1 recommendations. There are a number of Class 2A recommendations in these guidelines again, and I think the first one here is possibly the most important of all. And if you just look down to the last couple of lines here again, repair with residual MR, without residual MR, 95%, expected mortality of less than 1%, when performed at a heart valve centre of excellence. So we're now getting away in guidelines from statements about, or rather vague statements about, well, the repair has to be good and mortality is low, to start specifying what sort of centres these operations ought to be carried out in. And again, the theme is continued. And I should also just point out this bottom line here again. Mitral valve replacement should not be performed for treatment of isolated mitral regurgitation localised to posterior leaflet unless there's been a failed repair. And again, well, what is a failed repair? How do you define that? And of course that varies from surgeon to surgeon, from institution to institution. So what we come back to is quite a long way. So this paper was published by Ben, myself and a few others in the audience back in 2006, an attempt to start to look at what standards should be applicable to mitral valve repair services. And there was no evidence base. There was still no evidence base for this, really. This simply consisted of email traffic and a couple of meetings between a group of interested people. And we came up with a number of recommendations which I think still stand and which I think are largely echoed within the 2014 US guidelines. So if we stick to surgical issues for a moment, so volume thresholds, and these figures were plucked at the time, I have to say, largely out of the air. 25 repairs per surgeon, 50 repairs per institution. Not particularly ambitious, you would think, but still something that most units in the UK are not achieving. And we also had a number of recommendations in terms of audit, publication and dissemination of results. And in particular, mortality should be less than 1% and durability of repair over 5 years greater than 95%. But it is a system problem, and there are problems in late referral. Cardiologists and the referring system in general clearly need to get their act together. And part of the valve service of excellence, however you want to define it, is that you have to have an efficient referral mechanism and an efficient cardiological service. So this is the headline guidance from the AHA-ACC again. This is their statement, Class 2A, about valve centres of excellence. And I think it's just worthwhile having a very brief look at the criteria which they summarise what constitutes a valve centre of excellence. So these are the first 5 recommendations. And I think these are very similar to what we proposed in the UK in 2006. The language is slightly different. The content, I think, is pretty much the same. So experienced providers with expertise in multiple disciplines. All options for diagnosis and management, although they do come on to say a little later in the document that there may be some room for centres which only subspecialise in particular areas of valve practice. Demonstrate adherence to national guidelines, participation in audit, and continued evaluation and quality improvement. And the 6th, publicly report their data, because that is clearly very, very important. And in 2010, Ben, David Adams, a couple of others put in some suggestions for eliminating this so-called postcode lottery in the provision of mitral valve repair. And again, these still stand. They're very similar in actuality to what the ACC, AHA are proposing in terms of the mechanism for avoiding these discrepancies in repair rates and avoiding discrepancies in the success repair. So there is a theme developing here. There are recommendations for specialist valve clinicians from the British Society for Heart Valve Disease, from the European Society of Cardiology Valve Disease Working Group, and they're all heading in the same direction. So all of these documents are setting out standard in terms of transparency of outcomes, audit, transparency of process, and the need for some concentration of expertise. But it hasn't really happened. So just to summarise, the provision of mitral valve repair in the UK is variable. Outcomes aren't optimal. Patients referred too late. There are probably still too many replacements going on, and we're uncertain about the durability of some of the repairs because it simply isn't being looked at. And my personal view, and I know the view of a number of other people in the room, is that there is a building argument now, strong argument, for valve centres of excellence incorporated around valve clinic and expert surgical services. And I think the job that we have to do as clinicians is how to engage patients, certainly, our colleagues as cardiologists and surgeons and commissioners, in how to actually make this happen, because I think the evidence that something needs to be done in terms of service specification, publication of outcomes and commissioning is very clear. Thank you very much.
There's probably time for 3 questions. So can I kick off by just asking, from your perspective, how realistic would it be for, now, for there to be a few valve centres of excellence in the country, as opposed to each significant unit more or less having an obligation to set up a valve centre of excellence within it? I mean, transplantation is a very, rare thing, and it's reasonable to have 5 or 6, but mitral valve repair, is it now the case in 2014 that all cardiac units should have the capacity to perform safe mitral valve repair, meeting all the standards that you lay down? I mean, it's not rocket science, really, reporting data, etc.
Well, I mean, my personal view is, in principle, why that should be feasible. But I think there are arguments around volume. And so it's only feasible if you can maintain the necessary volumes to maintain expertise. And to some extent, that's a self-fulfilling prophecy, because if you don't do many, you're not going to be a centre, you're not going to do them. And I think if you're going to develop as a centre, I don't think you necessarily have to have a predefined number. I think you need to be able to demonstrate that you're providing a good service with high repair rates, with good outcomes, and actually you define the number of centres that you need on the basis of the outcomes rather than any a priori assumptions.
Can I make a comment on that? So you've got a situation, for example...
And let's ask the audience first,
yes, okay.
Because 3 questions, that's all. We haven't got much time. You did say that the panel wouldn't ask questions when we started, so...
Mr. Griffin. Norman, do you...
Yes, the other big problem, I think, is the setting up of heart valve clinics, because there are lots of cardiologists who, being in a surgical meeting, I feel quite free to come and bash cardiologists.
Part of the course.
Yeah, absolutely. It's setting up of heart valve clinics because, getting to that target where patients are being referred early is difficult. Heart valve clinics are crucially important, and yet getting cardiologists to give up all these hundreds of patients that they followed up in their clinic so that it goes through... I mean, I can't see the process how you would mandate the setting up of heart valve clinics in a way that we could possibly change practice on the surgical side. Because I personally feel changing practice on the surgical side would be
Where's the
easier.
question, Norman?
The difficulty with setting up heart valve clinics.
Yeah. So, I mean, I think the point you make is a very important one. This is about it's a service. It's not necessarily built around individuals. It is a service, and you need a number of components of that service. So there are plenty of places where heart valve, Sheffield being one, where heart valve clinics exist and where they work very well. And I wouldn't pretend that ours in Manchester is perfect. It's not, but it actually does function most of the time quite well. And I think you just have to set up a system which serves its end. And there's no reason, if that can be done in one centre, why it can't be done in others. In terms of mandation, well, I think there ought to, within the service specification of what a unit needs to be doing if they're going to provide this sort of service, a valve clinic and what that entails needs to be in there. It should be part of the service spec. And that is a job for CRGs.
Any more? Alistair.
I think you're in danger of setting up a new way of risk-adverse behaviour by surgeons. Just say you've done your 24 repairs that year, you've got one more case to do. I've got to repair that. And as Frank told us this morning, replacing the valve with complete subvalvular, that might be better for that patient.
Yeah.
And I think it's a real danger here when you're putting specific figures on it that there'll be more risk-adverse behaviour by surgeons to get into this elite club.
Yeah, I mean, I think you're right. That is a risk, and it's one reason why I personally favour a number, because I think you have to have a number in there, but I don't think you need to rigidly enforce that. I think what counts is the outcome. And that should be the defining nature of whether a centre is a valve centre of excellence or not. It's not necessarily the pure numbers, it's the outcomes. But within that, what you need to know is the people who did not get the repair. And that's lacking in all of these series, as was pointed out this morning. You get told the number of patients who had repair, but you don't know the number of patients who had replacements over the same time period. And that is a very important part of the data.
Whilst that may be right, and what I was alluding to there may not be right, this 6% mortality after mitral valve replacement may well be patients with an NYHA class 1 disease going to surgeons who are not mitral surgeons, full stop, and doing a good, proper valve insertion with complete subvalvular preservation that works perfectly is not a simple operation done by anybody frequently.
The other thing is the intention to treat, of course, because if the repair fails and then you replace it, the patient then has the massive run and they don't do well. Anyway,
I don't agree. Done well, they will do well.
Well, first time.
I think
The problem is that in the blue book, the intention to treat repairs that fail and are then replacements end up in the replacement, not the repair column. Anyway, Simon, many thanks. This is surgical squabbling.
thank you.